we're going to see the hepatic encephalopathy. Hepatic encephalopathy presents with asterixis. Asterixis is we will ask the patient to extend the hand and we will see this movement. Sometimes we would not be only need of extending the hands or arms. Sometimes we can help us to see this if we put a paper. We will see the movement of the paper if this is not very clear, or maybe we need to desencadenate this. We can just touch the patient, something like this, and then the patient will begin to do this. The patient would have altered mental status. There would be a musty odor due to mercaptans on the blood. The hepatic encephalopathy can be precipitated by gastrointestinal bleeding. So in a patient with esophageal varices that are now bleeding, for example, this can precipitate the hepatic encephalopathy, as well as the hypokalemia. Hypokalemia also precipitates this encephalopathy. The pathophysiology is that there is increase in the ammonia. Remember that this comes from the glutamine. Glutamine is deaminated, so we take out the some of the amine group, and we have glutamate. We will take out the amine or amida in the R group, and here we left with glutamate. But because there is a lot of this, that means that we are consuming a lot of glutamine. So the glutamine comes here because it's generating a lot of ammonia. So there is decreased glutamine, and because there is glutamine, the glutamate cannot be, or the glutamate is going, the reaction is going towards this way. Glutamate will be converted into glutamine. But if there is no glutamate, there will be no GABA, because GABA comes from the glutamate. What glutamate is being used to create glutamine, because there is less glutamine because all the glutamine is being deaminated to this. So there will be decreased GABA, and so the patient presents with, let's say, hyperexcitability in the central nervous system. For that the patient does this. For that all these sedative medications would be contraindicated because they can precipitate this. The treatment would be with neomycin, aminoglucoside, but it is very toxic, so usually we do not give this. We give lactulose to achieve 2 to 4 stools, and the issue here is that the lactulose will convert this into a more readily excreted substance and less toxic. The other is rifaximin. This is an antibiotic that breaks down the RNA polymerase, and so there is a antibiotic inhibits the proliferation of bacteria because the bacteria produces the ammonia. So we want to stop the source of this production of this metabolite. Now the treatment in hepatic encephalopathy is mainly with lactulose and rifaximin. Remember that the treatment of hepatic cirrhosis, the TIPS, can precipitate the hepatic encephalopathy. And the other thing is that patients with the hepatic encephalopathy have increase in the phenylbutyrate and phenylacetate. These are combined with glycine, glutamine, etc., and they are excreted on the urine, and so we can check for this.